Welcome to our breastfeeding class, and we're glad to be able to offer you a virtual option for a breastfeeding class at this point in time with all the things that are going on in the world right now. And so we wanted to be able to give this to you. We have some handouts available too on the hospital website that go along with this PowerPoint, and also some that have some links that might interest you further as far as learning about breastfeeding. There will also be some information about how to contact us, as there is also my email on the website. I'm Angela Hamby. I'm one of the lactation consultants here at East Alabama Medical Center. I've been here for a long time. I graduated at Auburn University in 1983, so I'll let you do the math. So War Eagle and whatever else to anyone else. I have been working labor and delivery and maternal child areas ever since I graduated from Auburn in '83, and I have 6 of my own children, all of whom I breastfed, so I'm very passionate about what I do, and I'm excited to share my information and my knowledge with you. So we're going to take questions about breastfeeding. I know we can't do that right here, but I am willing and open for you to email me or text me some questions as you may have them, whether it be in the next few days or weeks, or obviously as you deliver and get your new babies home. Anything specific you want to get out of this, be thinking about that. And again, watch those websites that we're going to give you. That may give you more information of things that you may want to look into a little bit more detail. And again, we're always available to help you with some of those things. Keep in mind that this has been a class that we've been doing in classroom with parents, and now we're offering this virtual option. So bear with me as I have to kind of run through that in my mind, thinking about how it's a little bit different today. But what kind of support you want to have after your baby is born is very important. So be thinking about that as you watch this, and again, as you look at the other resources that we might have for you. And of course, normally I would have so much fun getting to know all you guys, and so we hope in the future maybe to have some Zoom meetings where we can have some more virtual support, where we can talk to each other and coordinate and encourage each other and give out information. At this point in time, we're not quite set up to that yet, but we look forward to that in the future. So we're going to talk a little bit about how breastfeeding works and latching and positioning your baby, when to feed your baby, feeding cues, that sort of thing, getting enough milk, and just general breast care and the general lifestyle of not only breastfeeding, but just having a newborn at your house. It is amazing to know that you're helping your baby grow and be healthy. And if you, want to know more about how important your breast milk is for your baby, there's so many great resources out there. But one thing I always like to go back to is something I heard at a conference once. If you want to give your baby the greatest vaccine, it would be your breast milk, and it's so natural, and it gives your baby so many antibodies and immunities to so many things, not only now, but throughout their life. So the importance of breastfeeding, of course, as we just said, boosts your baby's immune system, enhances brain development, and I'm not really sure we totally know all that can do for your baby. I think the research is still out there as to how much it enhances brain development, but we know that it does, and I think we'll see more and more strides in the research that really proves that and shows the effectiveness of it. We know that it reduces the risk of childhood obesity, diabetes, and also SIDS. And those are some important things to note. For mom, it reduces the risk of breast cancer for sure, and other reproductive organ cancers. It does help lose pregnancy weight because you burn a lot of calories in making milk, and it helps the body just kind of get back into shape as it helps the uterus clamp back down after childbirth and delivery, and helps control the bleeding and thus get the uterus back in shape and kind of back in the area it needs to be in the body. And so that helps mom in general, not only weight-wise, but just kind of getting her body back where it needs to be. And breastfeeding hormones actually will relax you as baby's nursing. Many moms will tell us that they kind of feel sleepy and really relaxed and rested. Kind of like you do when you eat Thanksgiving dinner and you get some turkey and you feel real sleepy afterwards. Same kind of sort of release of hormones that help moms to relax. So let's talk a little bit about how your body makes milk. We're kind of familiar with the nipple area. The area around the nipple is called the areola. And nipples and areolas come in all shapes and sizes. My little model here. But inside of the breast is the ductwork and the alveoli where the milk-making tissue is actually located. And so it's very important, and we'll talk more about this as we go on today, about how the baby latches, how they activate those ducts to then get the milk out. And then of course the release of hormones that make milk production go into full gear. So the more milk your baby takes, the more your body makes. You might say supply and demand, but really I like to say demand and supply. So the more we demand, the more the body makes. And so the first trigger of lactogenesis or milk production is the baby being born. And that sets off a wave of hormones that cause your body to go into milk-making production. And then the next triggers are baby being put skin to skin, baby suckling, or even just nuzzling in those first few hours or even first 24 hours. Any of that releases more hormones that help mom ramp up that production. So the more the baby suckles, the more the body gets those hormones going, the more the milk production gets going. So in the first couple of days, we have what's called colostrum. And a lot of people will say to me, oh, I don't have any milk yet, I just have the colostrum. Well, it really all is milk. It's just different stages of the milk, if you will. So as the baby starts to suckle, the first things that they will get is the colostrum. It's more of a thick, syrupy looking milk. It's very concentrated, so there's not a lot of volume, but baby's tummy doesn't need a lot of volume at this point in time. And it's very rich in antibodies and just what the baby needs. And baby really only needs like 5 or 10 milliliters, which is about a teaspoonful or so, each feeding. Probably about 30 milliliters total for that first 24 hours. So see, we don't need very much of it. And again, the baby's tummy is very tiny, so the nature knows to give the baby small doses in a more concentrated form until that tummy stretches out a little bit and baby can take more in and mom's milk produces more. The second phase there is the transitional milk, and that's really around day 3 to 5, maybe even day 6, where you may still notice some of the yellow color to the milk. We actually refer to that as liquid gold. So it's a little bit of the colostrum, but mixed with some of the more mature milk. And very, very rich in nutrients and antibodies, but by now the volume is up and the consistency of it is more like what we think of as milk. And then when we get past day 5 or so, we're looking at more mature milk, more what we think about when we think about milk, and that's why it probably looks like a skim or low-fat milk. Some moms' milk are fattier than others based on their diet and other factors in their body. And sometimes that's an issue for some moms. If they don't have a lot of fat content, it can cause some problems with gaining. But overall, most all milk is going to look more low fat to skim milk looking at that point in time. All right, let's talk about some special situations as far as breastfeeding. Preemies or any other medical condition, if a baby's sick, it could be a term baby but have some respiratory issues, for instance, or some anomalies that may cause some surgeries or something like that. And so any baby in that situation, in fact, our protocol here for preemies is any baby 36 weeks and under, we're going to automatically set up mom to pump, even if that baby's able to nurse some. Certainly if a baby is sick, whether it's preterm or full term, and baby is separated from mom because it's in the level 2 nursery or has to go to another NICU because of other issues going on with the baby, we will get that mom pumping with one of our hospital grade pumps. Another situation would be our multiple births. We've had lots and lots of twins this past year, more than I've ever seen in all my years that I've been here. And we will set you up to pump. Again, even if babies are term, we would still encourage moms to pump. Because you got to make a lot more milk, and and a lot of times these babies are preterm or have some of the other things that we just talked about because they are preterm. There's sometimes other circumstances around a multiple birth that even makes it more important for mom to be pumping to make sure we get that milk supply well established, that we really stimulate that production in the first couple of days so that down the road, day 3, a week down the road, we've got a good milk production for not one, but multiple babies. Moms who have had breast surgery in the past, that could be something that was as simple as an augmentation or a breast reduction, or as complicated as maybe some kind of lumpectomy, maybe even a cancerous sort of thing. But as long as they still had the breast tissue, they should be able to try to breastfeed. It is something that we need to watch because the more the tissue is bothered, for instance, in a breast reduction, many times the ducts are cut and severed and they do regenerate. So, but if it's been a breast reduction in the last few years, a little less chance of mom having a good turnout with milk production than if it had been several years ago. So those are situations that we need to know that history, that mom's had those kind of things in the past, so that we can watch the milk production and the baby's weight and that sort of things a little bit closer. And those would be a situation where we would get mom set up to pump with one of our hospital grade pumps. And then donor milk. We don't have that option here right now, but I think we will see that hopefully in the future. We are seeing that more and more at some of the other hospitals in our state. I know UAB has access to that. There is a mother's milk bank in Birmingham now, and so that hopefully in the future we'll see more of that for our level 2 nursery, and maybe even in the future for people in general that maybe have a problem with having enough of their own supply. Right now, as far as donor milk, if you had a supply issue, that would be something that you'd have to look into on your own. But again, there is the Mother's Milk Bank, and I also want to remind moms that maybe have a great milk supply, if you happen to be one of those moms, that the Mother's Milk Bank does take donations, just like you would donate blood. It goes through a process, and if you're one of those moms who could feed the whole nursery, certainly think about that, particularly when you're weaning your baby, when your baby's older, 6 months, year old, whatever. You might want to think about donating to the Mother's Milk Bank of Alabama. All right. It takes two of us working together to learn how to breastfeed, and it certainly is kind of a team sport, you might say. Mom and baby trying to figure out what's going on. Dad or whoever the support person is, a lot of times we'll bring them alongside to help mom out. And so I hope that those of you who are watching this class are watching it with whoever your support person is going to be, because I can tell you that when we get you up here and we're working on breastfeeding, we're going to pull in that support person to help out, whether it's positioning mom or moving pillows or tickling baby and aggravating the baby to keep them stimulated or whatever. And some of this start list of doing things that need to be done to get you on the right track, of course, is choosing good healthcare providers. I'm sure that's the case for anybody that's delivering here. All our doctors, our staff, and I feel sure all the ones in the office staff are supportive and are going to get you in the right place to get the information that you need, and to us eventually either through class or at the hospital itself, so that we can make this the best experience for you as possible. Understanding your birth choices can affect breastfeeding, and a more natural delivery does make an optimal situation for breastfeeding early on than having more pain medicines, which make mom sleepy, baby sleepy. Epidurals even can have some effect. Long labors have some effect on that, but we don't really have a whole lot of control over that. So you have to always think what you want, but know what could happen and know kind of those options. And that's where we come in to really help you make that the best situation as possible. If you can have a doula or other support person with you, that's great. At this point in time, there is only the one support person, so I'm not sure exactly how long that's going to be, but I know for those who want a real natural birth, thinking about some of those options, and that would be something to talk with the birth navigator, which is another class you can sign up for through the childbirth unit. And tell the hospital staff when you come in that you're planning on breastfeeding, you really want to make this work, you've been to the class, questions or concerns you have about it from the get-go, and then tell the next person and tell the next person, and then finally you will see us and we'll talk about it too. Don't always assume that it gets transferred. Don't be afraid to speak up and say what you want, what you're thinking, or what your questions are. You want to make sure that you're holding your baby skin to skin as early on as possible, and that's just a routine that we do now because we are a baby-friendly hospital, and we changed a lot of our protocols several years back, and that's one of the big things that a lot of times we used to have to ask for that, and that's something that's just a routine thing. So you'll get to hold your baby skin to skin, and that is very, very much so going to promote early breastfeeding, because typically if babies go to chest with mom initially, they are looking for the breast and they're ready to try to feed. We do have rooming in, and so your baby would only be separated from you if there was a medical issue, maybe had to go to level 2, or for certain circumstances like the boy babies getting circumcised, that would be a procedure that's done outside the room. Otherwise, babies stay in the room with mom 24/7 while you're here, and we do everything in a bath, meds, that kind of thing, all in the room right there with your baby, so that you can learn how to take care of your baby, watch your baby's feeding cues, and other things while you have us right here to help you. We do suggest that you not have any pacifiers or artificial nipples or formula in those first few days, and we'll talk more about that as we go on. Alright, so benefits to skin contact. The baby stays warm and comfortable. He latches on better and breastfeeds longer. He really does cry less, because a lot of times in those first 24 hours or so, they really just want to be close to you. They don't even really care about feeding that much. But you got to remember, they've been inside of you for 9 months, and they really just need that warm body. It's very much a transitioning time for them in those first few hours of trying to figure out why you evicted them from their nice warm apartment and what happened to their 24-hour room service. So many times just being right here where they can smell the colostrum, which actually smells and tastes like the amniotic fluid, and feel your warm body and hear your heartbeat is really all they need. So don't be worried if they don't do a whole lot of actual suckling. Yes, we want to try, and we'll work with you on that. But if they're not doing a lot of that, then just let them be skin to skin, and y'all both rest and relax together. Both parents can do skin to skin. As you see, the dad in the bottom picture there, he's actually doing skin to skin, and that's a wonderful thing. For instance, if a mom has a cesarean birth and maybe she's not feeling that well, although she can do skin to skin even after cesarean birth, then dad can do skin to skin while mom's recovering in the recovery room. Still right there in the room together, but mom maybe doesn't feel as well as she'd like to be able to hold baby. All right, let's talk about some breastfeeding holds. Now the first picture in the upper corner here is obviously a baby that mom's home and baby's a little bit older, but you'll still see this layback hold probably in the delivery room, because when you're laying back, you've just delivered, and they put the baby on your chest, you're going to be in kind of that more laid back position. So that's something that could be initially, and it can be later. And you may have to help baby kind of find their way, but in those first couple of hours, babies are very good about looking for the breast and actually pushing up. There's a great video out there called the breastfeeding crawl that you can probably look up on YouTube, and you can see how babies are actually looking for that breast and finding that target and coming down on that. And so they kind of simulate that laid back nursing position, but again, that is comfortable too when maybe you're tired and you had a long night with baby or whatever, and you kind of need to rest and relax a little bit too, even when you get home. I'm gonna kind of hit the ones that I don't like as much, and then come back to the ones that we've used more these first couple days that you're here with us. So the cradle hold is what we think about when we hold a baby. We think about holding it in the cradle of our arm, and that's, some moms make that work very easily, particularly moms who have had second, third babies. But you really don't have very much head control on the baby. So it can work, but it's not always going to be the one that I'm going to recommend for you. Side lying, which we see down here at the bottom corner, is a great position for when you're tired, middle of the night, afternoon nap, particularly for more seasoned moms who've been breastfeeding for a while, moms who have breastfed before. But I don't recommend it really for my first-time moms, because you've got to get used to how this all works, and the baby certainly has got to get used to how this all works. And a lot of times babies don't get on well, moms fall asleep more, the latch is very shallow, and so it ends up hurting mom. So I don't really recommend that early on, but it's a great position as you get more in tune to what you're doing. Okay. Now let's look at the two positions that we like to use a lot when you're here, and that is the football hold and the cross cradle hold. And the reason for that is because you have good head control and good breast control, and that is key in getting baby positioned correctly. You want to have the baby kind of in your arm here, this hand kind of at the base of the baby's head, as you see in this picture here. You're giving good support on the head, because you got to remember, baby's little head is just kind of bobbling all over the place. They don't really have that much head control. And then they are supporting the breast in what we call the C hold, so around your breast here, so that you can help baby make that connection. You don't want your hands to be on the areola though, because you want baby to be able to get a good chunk of that areola tissue and not just on the end of the nipple. And a lot of moms, I'll see them, they try to pinch the nipple in there, or they try to, we kind of tease and call this the cigarette hole, holding it like that. We don't want you to do that. We want you to hold it in that C hold, and really you're holding the breast. You're supporting the breast, not the areola. We're going to get baby's mouth open really wide, and baby's going to come down on a good portion of that areola. If you got a small areola like this little model does, pretty much you're going to take the whole thing. If mom has a large areola, which some moms do, they're going to take a good portion of it, and they're going to come on it from sort of the bottom up. So they're definitely going to get most of that areola at the bottom, and you may see just a little bit at the top. Okay? So that gives the baby where they come off just a little bit, so they have a little bit of room for their nose, but don't feel like you have to push the breast tissue back so much that you're pushing areola tissue out, because you've got to see the whole nose. You don't. Babies' noses flare out to the side so that they can breathe even when they've got breast tissue all on their face. And they'll pull off if they really can't breathe. And really you only need to see a little air pocket on the side. So a lot of times from mom's vantage point, it looks like there's all breast tissue in her face, but really there's not. Really there's a nice little air pocket in the side. So that's where we come in and helping you see that baby is on there, nice and deep. We'll talk more about that in some pictures later. But also, baby still's got plenty of room to breathe. Kind of reassuring moms of that. Okay? So that's really those things that I just talked about as far as support and supporting the breast are true for cross cradle or football. The only difference is that you've got baby in front of you versus baby on the side of you. Okay? So if you're doing football hold, you're going to have your pillows. As you see, mom's got some pillows there stacked on the side of you, and you're going to have baby's feet back behind you, and you're going to have baby on the side, and you're going to be holding them like a football. And you're going to have this hand on baby's head and this hand on your breast. And another big key component of getting a good latch is making sure that baby is turned towards you. So as you see in this picture, baby is chest to chest with mommy. In this picture, baby is kind of chest to side with mom. You don't want baby laying like this, and mom's here say, and baby's stretching to get onto the breast, because then they're having a hard time swallowing and they're having a hard time getting further onto the breast. And we want to make it easy for them to get as far on there as possible. So you want to have baby's ear, shoulder, and hip kind of aligned there, and they're turned in to mommy. Baby-led breastfeeding is just kind of what it says. You're kind of laying back, again talking about that first picture we looked at in the previous slide. A lot of times that's what's going on in the delivery room. We may or may not, in that situation, use as many pillows as we would once you get to a postpartum room or even at home. But certainly using pillows to help prop mom's arms or back so that she's not straining and she's comfortable. Very important for mom to relax so that baby doesn't pick up on her tensions or anxieties. She's not tense and stressed, and that also helps to let milk down. So you place the baby across the chest, across your body basically, and you position the baby so that the head is under the breast. And remember we talked about the baby's mouth coming bottom and over. And the baby may actually move to self-attached, or as we said before, you're kind of guiding the baby with your hand by having head and breast support. So you want to sit comfortably. This is, of course, obviously a mom that's a little bit further down the road. She's at home. Feet supported a little bit. In fact, if you've got like a little stool or some books under your feet that bring you back in the chair, that's helpful, so that you bring baby to you rather than you leaning into the baby. Hold your baby close, tummy to tummy, as we mentioned before. Keep your hand behind the areola. We talked a lot about that. Line the baby's nose across from your nipple. Tickle his upper lip. When the baby's mouth opens wide, pull him in very quickly and get him deep on not just the nipple, but onto the areola. Okay. An effective latch. We've got a mouth that's wide open, big fish lips. The lips are flared outward. There's a large amount of breast tissue in the baby's mouth. There's more areola above than what we can see below. We should see movement from the side of the mouth up to through the jaw up to the ear. So movement here, and you should see a dropping of the chin, which means they're swallowing. And mom should feel a strong tug, but it should not hurt. So if you're hurting, then you need to let us know, because we need to look at what's going on with that latch. Is it a shallow latch? Is there an oral anatomy issue that we need to talk about? Is baby pulling its tongue back, which sometimes can cause mom some problems with the latch? Is baby sucking its own tongue? Sometimes that's happening. They've gotten in a habit of that. It makes it very difficult for them to get a good, comfortable latch if they're busy going. So if you're hearing a lot of noise, that's a big sign that they're sucking their own tongue or lip, and we need to talk about that. Some people mistakenly think that, oh, I'm hearing a sucking sound, that's good. You really shouldn't hear anything at this point, okay? So let us know if it's hurting. All right, so ineffective latch. Mouth is not open wide. There's only a small amount of breast tissue. So you see a lot more areola tissue on that picture. Hear a clicking or a sucking sound. It's painful, and it's the biggest common cause of sore nipples. So sore nipples, hurting nipples is not supposed to happen. I have moms tell me all the time, oh, somebody told me it's going to hurt. No, it's not supposed to. And so if it is, we need to try to fix that. All right, here's two slides that show you the difference in a deep latch and a shallow latch. And in the second picture, you can see how much more of the areola tissue that you can see. That right there tells us there's an issue. You cannot see that here. And the big thing I want you to look at is how far the nipple is in that baby's mouth. This one's way back there, and this one just barely. Let's talk a little bit about that. If you put your finger in your baby's mouth and feel right behind the gum line, you're going to feel a soft, hard area right behind the gum line. That's called the hard palate. See in that second picture. If you put your finger further back in the baby's mouth, in the roof of the mouth, you're going to feel a softer area. That's called the soft palate. And that's where we want the nipple to end up. Okay? That's what needs to happen in order for baby to make the right seal and sucking motion on the nipple to make the milk eject. Okay? If the baby's here and it's hitting that hard palate, guess what? It's really hurting mom. Okay? And then sometimes it's not even making the right seal on the breast, so the milk's not coming out, and then the baby sucked harder, but in the wrong place. And what do we end up with? Really sore nipples. So that's why, again, if it's hurting, we need to talk about it, we need to look at it, we need to make it better, or it's just going to get worse, kind of like getting in a vicious cycle. You got to break that cycle. And there's a number of different things that we can use. One, let me just mention before we go to this. Besides just doing an assessment, trying to get the latch deeper, trying to work on mom's positioning, there's a thing called nipple shields, and that's one of these little gadgets right here. And they just fit over the breast. It gives a barrier between mom and baby that sometimes can make the latch better. It sometimes can actually help babies open their mouth wider. And if babies have any kind of tongue restrictions, it actually can help them make a better seal on the breast to pull the milk out. So many times, we try not to use them in the first 24 hours if at all possible, unless you have a real inverted nipple. But sometimes for a bad latch or latch issues, we will use a nipple shield. They do come in sizes. You do not necessarily need to bring them on your own. We have them here and we'll size you for one and give you one, and then you can buy spares. Okay, let's talk for a minute about pacifiers. So I mentioned earlier that we don't recommend pacifiers. That's one of the things about promoting breastfeeding and being baby friendly, is that we do not recommend pacifiers, especially for the first few weeks, until breast milk production is well established, breastfeeding is established, and then only sparingly, not to make babies get on set schedules. So if baby needs, 2 hours, wants to eat, baby needs to eat again, not because you want to make him wait till that 3rd hour. So pacifiers, as this shows, really kind of hold off those first few weeks until milk supply is well established and baby knows how to suckle well and is gaining well. And then there's the kinds of pacifiers. This actually shows a Nook pacifier in this picture. We really don't recommend those because many times those cause mom's nipple to slant because the side of this pacifier is slanted. We like to use, if you're going to use a pacifier, the ones that are more symmetrical around. This particular brand is a gumdrop. There's a Soothie out there. I think there's even a Playtex one that is more symmetrical around and more elongated, which is how your nipple is supposed to look when it comes out of baby's mouth. Elongated and symmetrical, not smushed, not angled, not flat. And after a couple of weeks, feeding baby may become kind of second nature. And there are going to be a few little hurdles here and there, especially in the first couple of days. And many moms leave here at 48 hours or so feeling pretty good about things, only to go kind of through another hurdle in that next 24 hours. So if that happens, don't dismay. That's all part of the getting used to things, getting that milk in. Babies get to nursing well, and then milk comes in and the breast tissue kind of changes, and we kind of have to go through that little hurdle. But after a couple of weeks, things do get more and more routine for you. Let's talk a minute about feeding cues. You'll hear us talk a lot about you want to feed the baby on cue or on demand, and the things that we look for are these different pictures you see here. First, one of the first feeding cues is just that open little mouth, that little bird. Where's it at? Sucking movements. They might be licking their lips, sucking their tongue, hand to mouth, or sucking on their fist. Moving or fidgeting in the bed. Certainly rooting around. They pick them up, they're trying to root on dad or grandma or whoever's holding them. That's definitely a feeding cue. One we don't have up here is just when they're still kind of in a sleep, but you start to see some rapid eye movement, or you see a little bit of that tongue like moving around. Those are all feeding cues. If you're having a baby that you're having a hard time getting them to latch and nurse, you want to watch for those very early subtle feeding cues, and you certainly want to watch for these more obvious ones, and that's when you want to key in on trying to feed the baby, because you'll be much more successful. You don't want to wait till baby's crying, because then they're already kind of mad at you that you hadn't already fed them. Okay, so they're giving you signs that they're ready to eat with these things previously. And particularly for a baby who's having trouble latching, we want to pick up on those early feeding cues and go ahead and put them to skin and then to breast. So what are kind of the feeding guidelines? Feed your baby whenever you see hunger cues, feeding cues. We like to say 8 times at least in 24 hours, 8 to 12. So 8 is great, 12 is even better. Because in these first few days, they're really working on trying to get that supply up. They're eating small amounts, so they're going to eat more frequently. And even for a couple of weeks down the road, they're probably going to be eating 8 times a day, because the breast milk is very digestible. It goes through their little systems fast, and it's not like us that we're eating 3 meals a day. They need to eat much more frequently than that. And yes, you do want to wake the sleeping baby. So 8 times in 24 hours figures out to about every 3 hours. So you may hear people say baby's got to eat every 3 hours. That doesn't mean only every 3 hours. So at 2 hours if baby's giving you cues, at 1 hour if baby's giving you cues. Sometimes babies want to do what we call cluster feeding, and they may feed a whole lot, and then you may go a little bit of a longer stretch. But if they're going past that 3rd hour, they hadn't woke up, they haven't gotten any feeding cues, you need to wake them and you need to try to feed. And I would say if they didn't do anything at that 3rd hour, then I would try every hour until I get them to have another good feeding. Many times by 3.5 hours, they're like, oh, I'm ready. And so you go ahead and feed them then. But sometimes I have seen moms, especially in those first couple of days, you know, they try at the 4th hour, they try again at the 5th hour. But we're going to be doing lots of skin to skin, and we're going to be really working on that. And if we're past the 24-hour mark from delivery, we're going to be looking at some other things. If we've got a baby who's really going way long stretches, we're probably going to be looking at, you know, is there a latch issue? Do we need to set mom up to pump? Those kind of things. How's the wet and dirty count? Those sort of things to make sure that we don't need to intervene in some way. It is okay to offer both breasts at each feeding. There's really not a set rule on that, but typically in these first couple of days we suggest to do 5 to 10 minutes the first day, 10 to 15 minutes the second day, and therefore on each side. Sometimes babies will only do one side, and that's fine. Then you'll start on the other side the next feeding. If you do both sides, you'll start on the side that you finished on, because typically they do less on that side than they did on the first side. And again, we mentioned cluster feeding, and that's very common in those first few days. It's also very common as babies go through growth spurts. So like around the month old, 6 weeks old, they go through growth spurts, and they may cluster feed because that's making your body make more. The more we demand, the more the supply goes up. And looking at the little cartoon down here of the baby, sometimes I burp, sometimes I don't, but it doesn't hurt to try. And I always tell my moms, go ahead, especially in those first couple of days, you're probably not going to get a burp, but go ahead and sit the baby up in your lap in between sides and see if you can get a little burp out of them. And then at the end of the feeding, you can put them up on your shoulder like we're all used to burping babies. Just put them up on your shoulder with a cloth there to catch any spit up. But you're probably not going to have that much in the first couple of days. That comes more when that full milk comes in, and then getting spit up on, and even sometimes more projectile throwing up is not uncommon. If they were doing that every feeding, I would be a little concerned. All right, why do newborns have to eat so often? We kind of mentioned that just a minute ago. Their tummies are very tiny the first couple of days. They're about the size of a little marble. And they hold about 2 to 10 milliliters. Around day 3, which is usually their first day home, they should be taking around 15 to 30 mils, and that's per feeding now. I mentioned 30 mils the whole day earlier in the video, but we're talking now per feeding. So milk supply has gone up some over the course of the couple of days, and that's about what they would be taking. That's about 1 to 2 tablespoons. And then this one actually goes to day 10 with the size of a large egg, or an Easter egg in here. I usually kind of use the reference. Most babies at about a week old, average size babies, are taking about 2 ounces, which is 60 milliliters. So that just kind of gives you an idea of what their intake should be. Of course, if there's any need for any supplementation, be it with pumped breast milk or formula, we would certainly be advising you about that on a case-by-case basis. But because their tummies are so small, especially in those first few days, they eat a whole lot, very often I should say, and it goes through their system very fast, so they need to eat more often. Okay. Some babies are just not as interested in eating as others. They're very sleepy for different reasons. So we always recommend, particularly in these first few days, particularly here, but even the first few days home, undressing the baby. It's a good idea just to change their diaper before feeding. Holding them skin to skin for a few minutes, maybe to get them awake. A lot of times they get next to mom, they smell the milk, they feel her body, they start looking for it. Stroking his arms, his tummy, his face, trying to get him alert. And then even doing some hand expression into the baby's mouth or on their lips. You can literally, and we'll show a slide here later, how to hand express, but you can do kind of that C hold again, and you can literally massage on your breast and express a little milk that may get them interested in actually getting on the breast. And also that massage during the feeding, baby's already on there, will kind of keep them interested in nursing. All right, so wake a baby during the feeding. Again, we're talking about compressing your breast because they'll respond to the flow. That milk keeps coming. If they've kind of gotten lazy and they're not sucking, I'm guessing that active sucking, just because they're on the breast doesn't mean they're getting milk. They've got to actively suck. And so sometimes actually getting some of that milk to go into their mouth will get them sucking. Aggravating them, just rubbing a foot or back or hand or whatever. I like to tickle under their chin right here. I always give that job to the dads. They can aggravate them here, or they can pull on their little arm. I call that the crank them up, get them to keep feeding. Switching breasts sometimes can be helpful. In fact, if you're going from one side to the other, remember a while ago I mentioned when we're talking about burping, sitting them up in your lap. So versus putting them up on your shoulder like we normally do, I would suggest sitting them up in your lap, kind of leaning them forward, putting this hand on baby's head, and then using this hand to rub and pat baby's back, so that you can get a burp out of them and really just kind of get them awake. If you put them up here, they tend to just kind of go to sleep, but if you sit them in your lap kind of away from you, or even hand them off to dad to burp, then they tend to get more awake again, and then you can go to that other side. And then even in the middle of the feeding, changing a diaper can kind of get them really stirred up and get them going, particularly for a baby who's you're having a hard time keeping them awake and keeping what we call engaged in the feeding. Because some babies, they don't really care what they eat, and others want to eat all the time. All right, so we know that, again, the more the baby nurses, the more milk the mom makes. And that's true too as we move down the road. Once the milk comes in fully, the more mom empties the breast, whether that's baby feeding or mom pumping, if that's the situation, the more it tells the body to make. If we go long stretches without baby nursing or long stretches without pumping or either one, then the body thinks you don't want the milk, so you actually affect your supply. So you have to be careful about that in situations like going back to work, or when there has to be some supplementation for medical reasons or whatever. We have to make sure that we are stimulating mom's supply. That's the reason moms are set up if their babies are separated from them, because we've got to stimulate that supply to keep that supply, to get that supply going, and then to keep it going. All right, signs of getting enough milk. And this is something that kind of really changes over the course of the first week or so. The big things that we're going to look for in the first couple of days is, A, baby's actually doing something. Okay, you're seeing them get on there, you're seeing them actively suck. And B is how many wet and dirty diapers they have. And there's actually a chart coming up that shows how many they should have each day. And we look at the weight somewhat, but babies are going to lose some weight in the first couple of days, maybe even as much as 7 to 10%, and that's okay. We don't really expect them to be back to birth weight until they're about 2 weeks old, but we don't want them to lose a ton of weight either, so we watch that very closely. Now, you're not going to hear so much of a swallowing in those first couple of days because there's a little volume, but as the milk comes in more around day 3, 4, 5, you should hear swallows, and all that time, even in the beginning, remember I said we need to be looking for that sucking, and we can actually look for that swallowing, the jaw drops. When baby's done, they get more relaxed. So if your baby's at the breast, a lot of moms will tell, oh, my baby just, like, I put it up here and it just fell asleep, and I'll go over there and I'll pull that arm is just really tight, what we call tension in the arm. And when I try to crank that arm up, it really doesn't move very much. So those babies are not really asleep. They're just being a little hard-headed and not really sucking like they need to. So those are babies that we need to really stimulate. We need to tickle them, pull on that arm, wipe them down with a wet washcloth, whatever we need to do to get them sucking effectively. Because otherwise they're just kind of, as I say sometimes, they're playing possum on us. So when they're really done and they're getting what they need, they're going to just come off kind of limp, okay? We sometimes call that being milk drunk. And you're especially going to see that as that full milk comes in around day 3, 4, 5, when they definitely are getting more and getting way more satisfied. Now, not so much in the first couple of days because you're really not going to feel any fullness or see a lot of leaking in the first couple of days, but as the full milk comes in day 3, 4, 5, The breasts are going to feel really tight and hard when it's time to feed, and the breast should feel softer once you have fed and the baby's emptied the breast well. And as we get more into that 5th, 6th, 7th day, you are going to see more periods of baby being awake and calm during the day and not, just wanting to continuously be at the breast. If they're wanting to feed, by a week old, if they're wanting to feed like every hour, then you need to be calling us and we need to assess what's going on, because that usually tells me baby's not really getting what they need for different reasons. It doesn't mean you don't have the milk. It may mean that they're not transferring the milk. All right, here's the diaper count that I was telling you about. So on day 1, we should have at least 1 wet and 1 dirty diaper. So that's one of the big things that we're watching for in that first day or so. And we actually give you some charts that talk about that, and nursing staff and us and y'all are all watching that. Day 2, we want to see 2. Day 3, 3. So it's pretty much how many days old they are for that first week of life. And then at the end of that first week, it's about 7 to 12. In 24 hours, they're not going to have 100 diapers at day 100, so don't have to worry about that. And then the color of the diapers, as far as the stool, changes. We start off with this real thick, tarry, it's called meconium. That was the first stool, and they'll have that for 24 hours or so. And then as they get more and more milk in, it will change to, you'll see kind of a green undertone to it, then to a dark brown, and then finally to a yellow, runny, and seedy, okay? And that's what normal baby poop looks like. Some people sometimes will call me and say their baby's got diarrhea, and typically no, it's just normal baby poop. Remember, they're only putting liquid in, they're only going to get liquid out. So it's going to be runny, probably even runnier than what that looks like. It's kind of a mustard color, and it has little seeds in it, and that's all perfectly normal. That's what we're looking for. Okay, and as we mentioned, the baby may lose around 7% of their birth weight in the first few days, even as much as 10. If they're somewhere around 7 or 8% when y'all go home, when you're discharged from the hospital, we will talk to you about a feeding plan, probably some pumping, and giving the baby the extra milk that you pump, and possibly even some donor milk if you have access to that, or formula, ready to feed formula, so that the baby doesn't get down until your full milk comes in and you are pumping more. It doesn't mean you're not going to get milk. Some moms just don't have it at 48 hours like they need to. Sometimes even at 72 hours out, mom's milk hasn't quite come in. Remember, there's kind of a 3 to 5 day window there. But babies in that 3rd day start to get really hungry and their needs need to be met. So if their weight's going down too much, or if the diaper count's not where it needs to be, we're going to set up a feeding plan for you before you leave. Or if you have problems that first night or so home, call us and we'll talk to you about a feeding plan then, even if we didn't have one before. Those are going to be things that we're going to talk to you about. Watch this. If this happens, if this happens, if this happens, call us and we'll set up a plan for you of how to handle that situation for your particular baby. We typically see the babies back for first-time moms the next day, so that we can make sure things are going well. So you come to our lactation office, which is just down the hall here, and we'll weigh the baby and check the jaundice and do a feeding with you to see if baby's transferring well. So that'll be scheduled prior to your discharge, and you will be able to come back with your support person, and we'll meet you over at the mother baby reception desk and bring you over to our office. Typically, as I mentioned earlier, babies should return to their birth weight by the time they're about 10 to 14 days old, so around 2 weeks old. So you're going to see us if you're a first-time mom in that first day or so home. You're going to see your pediatrician a day or two later, and then if things are going well, you won't see them again until 1 month. But if their weight is a little bit lower, they'll either have you come see us again or see them again in the office to make sure that baby's gaining appropriately. We are available for any one-on-one appointments as far as pre and post weight feedings. There's lactation consultations for latch issues on an appointment basis. Unfortunately, at this point in time, we're not able to offer our support group like we have in the past, but we are available for one-on-one appointments. There is no charge for those, and so if you were to need a weight check, say 1 or 2 weeks down the road, because you felt like baby was not latching well, baby was not seeming satisfied, certainly call us and we'll set that up for you. A pre and post weight feeding means that we weigh the baby in grams, we let you feed the baby, and we re-weigh in grams, and that can tell you by subtracting those numbers how much milk your baby transferred at the breast. That's very helpful information if we have a baby that's not gaining well, but appears to be nursing well. That, along with mom doing some pumping to see what she's actually producing, would be kind of the course of action we would take on that. All right. Some of the things to call either us or your healthcare provider if baby is not eating at least 8 times in 24 hours. This would be when you go home. The skin or eyes become yellow or jaundice. We'll come back to that in a minute and talk more about it. There are less than 3 stools by day 3, going back to the chart that we had earlier. Less than 5 wet diapers in day 4 or 5. Reddish or orange stain in the diaper after day 3. That's called urea crystals. That means the baby's a little bit dry. And sometimes you're going to see that around day 3 or so. But if you're seeing that a lot, baby's not really wet at all, baby's not latching well for you, those are some things that definitely would want to call us. Urea crystals are when the baby's a little bit dehydrated, and we don't want that to go on. Hopefully milk's coming in and you're starting to pump some, and you see that sort of going away. That's great, but you certainly don't want to see it over a period of a few diapers. If you saw that 3 or 4 weeks down the road, I'll be very concerned, because we might have thought baby was gaining well, and all of a sudden maybe the milk supply has dwindled for some reason and baby's not getting what they need. So definitely want to let us or your pediatrician know about that. Stool patterns change suddenly. Well, they're changing over the course of those first few days, so I don't know that you can, when we say change suddenly, I don't know that you should think about that in the terms of those first couple of days, because they're changing from that dark to the not so dark to a green to a brown and to a yellow. So just don't think about that part of it. But getting down the road, if your baby was having, a poopy diaper after every feeding and then went for 2 days without a poopy diaper, that might be something you want to let us or your pediatrician know about. Now, when babies are about a month to 6 weeks old, typically they do change stooling patterns, and they don't poop quite as much as they did in those first couple of weeks. But lots of poop in those first few days and lots of gassiness is very normal, so that is okay. We do need baby to return to birth weight in 10 to 14 days, and like I said earlier, most of the time if baby's weight was down significantly, either with us or with your pediatrician or with both, one of us are going to have you come back and have a weight check at one place or the other before that 2-week mark to make sure that we're on the right track. Okay. If you're always having to wake your baby to feed, baby should wake up. You shouldn't go on 5 or 6 hours in that first week or so, and your baby's, I know it sounds great that baby's sleeping a lot, but it's really not a good thing. And babies, most newborns are not going to sleep all night. I know it sounds good, but it really is not a good thing. Typically when moms come in and tell me, oh, my baby slept all night the first night home, I was like, that probably was not as good a thing as you think, because again, they need to eat more frequently. The hormones that help you make milk in those first few days are actually higher at night, so those nighttime feedings are very important. So we really need babies waking up, or waking them up on a regular basis, so that they're not losing more weight. So I've got to, one thing that I would have on a feeding plan if the baby was losing weight would be, you got to wake the baby at least on that 3rd hour if they're not waking on their own. So certainly if they're not waking up, then you need to let somebody know. Now, we're 4 to 6 weeks old, that's a different story. We're talking about these first few weeks. Let's go back to the jaundice. I wanted to kind of skip it and come back to it because it's a little bit more complicated. Jaundice is the yellowing in the skin, and it's caused by a thing called bilirubin that builds up in the bloodstream. We all have bilirubin in our bodies. We all are, because it's the byproduct of the breakdown of red blood cells, and we're all breaking down red blood cells all the time. But in our bodies and in older infants, they can throw it off fast enough. It's thrown off in the stool. But in infants, and some newborns more so than others, they can't throw it off fast enough. And so it builds up, it causes the jaundice color. All babies are going to have some jaundice, but some babies have a little bit too much jaundice, and some can have critical levels of jaundice, or critical levels, I should say, of bilirubin that can cause some real problems, such as brain damage. And we never let it get in those high levels. That's why we watch it really closely. If babies have any risk factors, we might actually do a reading for the jaundice in the first couple of days. We definitely do one at discharge, so at 48 hours, all babies are going to get what we call a jaundice meter. That's where we check a skin level here and on the chest. And then if that's a certain number, we have a little graph that we go by, then we actually draw some blood and check it. And so if that number plots out high, then the babies may actually go under what's called phototherapy, and that's just some lights, kind of looks like they're in the tanning bed. You may have had some friends that had their babies under phototherapy, and maybe it caused them an extra day in the hospital. Sometimes babies develop that after they get home, and they have to come back to the hospital for a day or two. But again, in those higher, lower numbers, we're okay. We do the phototherapy, and they're usually good in 24, 48 hours. We don't want to get it to those really high numbers where we would have some problems. That's why we watch it really closely. And so if your baby is looking like I sometimes say it's a glowworm when you get home, they're really, really yellow, they're not feeding well, they still got dark stools, those are all signs that we would definitely want you to call us and get that checked. Again, that's one of the things that we check on our checkup on those that third day. If you come back with a first time mom and baby, we're going to check the jaundice, and if it's too high, we're then going to draw some blood and check that and see if we need to do something. But again, we're checking it here initially, we're watching that, and then if you come back in to see us, we're checking it. It's usually not a big deal after that first week or so, and the more days old baby is, the less, the numbers can be a little bit higher and not be a problem. Now, some of the things to think about as far as risk factors. Preterm babies are more at risk for jaundice. Certain blood types are more at risk for jaundice, and certain ethnic groups are more at risk for jaundice. So those are just some of the things that we kind of know to watch those categories a little bit closer. Okay. So very, very often the night that you go home from the hospital, the milk came in really good, you woke up in the middle of the night and your shirt was soaking wet, and the baby began to eat a lot more. Or the other thing that sometimes happens is just getting ready to come in. I think I hear this probably even more so. Baby ate just like marathon fed all night long, and then the milk came in. So a lot of times they will kind of marathon feed right before the milk comes in. So somewhere around 2 to 3 days, typically we say about 72 hours, particularly for first-time moms, the full milk comes in, the more mature milk. Your breasts are going to feel fuller, firmer, and heavier. So the body's starting to make that more mature milk, which is, again, more plentiful in volume. And your breasts are going to feel like sometimes like they're going to explode. But that's only going to be kind of a passing thing. They're not always going to feel like that. They're going to feel tight and full when it's time for baby to eat, but it's going to get better as they empty, and it's going to get better over the course of the next few days because the breast tissue will adapt to that new fullness. So don't think that you're always going to feel like every 2 or 3 hours you're about to explode. And there's some things that you can do to help manage that fullness and prevent what we call engorgement. So hand expression is really helpful in helping to manage that engorgement. It helps relieve the uncomfortable fullness. It sometimes prevents bad engorgement, which can lead to some other problems. It sometimes can actually soften the breast so the baby can latch on, because sometimes the whole areola gets so tight, which is another situation where we might use a nipple shield because the whole areola is so tight, baby can't grab onto the nipple. It's almost flattened the nipple to the areola, so that's where nipple shields can sometimes come in handy at that point in time. It's another use for them. And it can actually protect and improve milk supply. So to hand express, you would massage your breast, much like we kind of did in that C-hold earlier, but just massage them with just your fingers there is good also. See, now she's got her hands in the C-hold, and so you kind of massage all the way around, and then you come in the C-hold and you're going to kind of push back, push forward. Pushing against the chest wall, and then squeeze it. And you may see just little drops, but as you move around, because you're kind of hitting the different ducts in the breast, especially as full milk begins to come in, you'll see just streams coming out. They'll kind of shoot out. And that's hand expression. We might have you do this even in the first day if we're having trouble getting baby to latch, if we're needing some milk because the baby's got a low blood sugar and we need to see some quick. And certainly in this day 3, 4, 5, when milk's coming in and you're really full, it helps to soften the breast up. It helps to relieve a little bit of that engorgement. Again, it helps to make the milk come down and get baby to keep suckling. So knowing how to hand express, and there's some great sites out there. If you look at our list of breastfeeding links. There's a couple on there that talk about hand expression. Be sure and look at those because hand expression can really be very beneficial at many different times. All right, relieving engorgement. You want to massage the breast to help that letdown, as we mentioned. You may express some of that milk to have a little bit on there, so as soon as baby gets on there, they taste the breast milk. And warm compresses before feeding are helpful in softening up and letting that milk down. So a warm shower or just warm cloths around your breast can be helpful. And then after feeding, particularly in those days, first days of milk coming in and engorgement, using an ice pack to reduce the swelling, because sometimes there's just swelling in the tissue, or expressing some milk until you have the pressure is relieved a little bit, whether that be hand expression or by pumping. Both of those things can help in helping that engorgement not be so uncomfortable and helping baby be able to latch better. So warm before and cold afterwards. That can be just a cold towel or it can be an actual ice pack. So we talked earlier about the latch and how that can, make for a sore nipple. It really shouldn't be sore. So let's talk about some things that can help. Of course, we mentioned how the shallow latch is a common cause, but some of the things that can kind of almost exacerbate that is if you break the suction on the baby's latch, like just kind of yank them off of there. That can hurt your nipple. If you're pumping and you just yank the flange off of your nipple, that can hurt the nipple. So anytime you're going to break the suction, whether it's baby or the pump, put your finger in the corner of the baby's mouth and gently break that suction before you pull baby off. If you're pumping, stop the machine. It cuts the suction, but then kind of press on your breast before you just yank the flange off of your breast, and that will help take care of your nipple. If you're pumping, make sure your nipple's in the center before you turn the suction up, and make sure you're not turning the suction up to where it's hurting you. Those are things that can kind of keep you from getting sore. Besides what we've already talked about getting that latch. That's the latch and how it is shallow or deep, and issues with that, like maybe sucking his tongue and stuff, are the big culprits, but these are some other culprits. You don't want to use harsh soaps. You don't want to keep wet breast pads in there. If you're a person who leaks a lot, everybody doesn't leak, so people just get really tight and hard and they get engorged like we talked about last screen. But so some people may not need breast pads, but a lot of people do. And there's different ones. There's washable ones, there's disposable ones, there's silicone ones. There's ones that you can even like let your breast milk leak into, and you can save the milk, called milk savers. So, but you got to be careful about changing those things out. Okay. And if you're having some problems, particularly with nipples that are cracked, bleeding, rashy looking, hurting, obviously, you want to get in touch with us. We need to look at that and decide, what is the issue? Is it the latch? Is it some other things that you've been doing? Do you have a yeast infection on your breast, which can then get up into the breast and cause even more problems? You need oral medication for that. What is the problem? You don't need to go weeks at a time with nipples like that. You shouldn't have to. So be sure you let us know if we evaluate that. We mentioned earlier that nipples and areolas come in all shapes and sizes, and they do. And sometimes we think of this protruding nipple as one is the best one to have, the right anatomy, if you will. But really and truly, sometimes that one is the one that has a lot of problems because babies tend to just kind of clamp down on that nipple that's very everted. And remember we talked about if we kind of clamp down on it, baby's not going to get milk out as well because they've got to be up here to put pressure on the ducts to make the milk eject. So if you've got this nice protruding nipple and baby's right here with their latch and not further up, then what's going to happen? It's a lot of pressure in a small amount of area, and mama's going to get sore and hurting. It's not because it's not a good latch. And so where it looks great, it's not where it needs to be. Maybe it needs to be on the bigger part of the areola and not just on the nipple. A flat nipple, you see that second one is one that would possibly need a nipple shield. Textbook says to try not to use them for the first 24 hours because sometimes for extra fluid during during labor and stuff. It'll make mom a little bit flatter there, and the next day it might be a little bit more normal looking and be a little bit more protruding and able for baby to get on. So we try to work with babies and moms to get the baby latched on, but if we're having some real issues, we'll go ahead and get one of the nipple shields. Now, an inverted nipple is one that is just what it says. The nipple is literally inverted, and nipple shields probably would be something that we would use pretty much from the get-go if we pick up on that, because that's probably going to be the best thing. That, along with some pumping that can pull that nipple out, will help mom be able to latch that baby up. And some people can have not so flat nipples in the first couple of days, and then when that, as we were talking about in the last slide with the engorgement and all, when that engorgement happens and the breast gets so full of milk, it makes the whole areola very tight, and so baby can't really grab onto it. So a somewhat flat nipple can get really flat in those first couple of days of milk coming in, so we'll watch that as well. So engorgement not related in 24 hours. Definitely let us know, call us. You've got our cell phone numbers will be on the materials that we give you when you first come to the hospital. They'll be on the link with this video. You will definitely have my email. And so don't hesitate to call, text us, email something, and let us know that you're having some problems and we can address that. A lot of times we can do this over the phone. So in this day and age of virtual stuff, there's definitely some things that we can do virtually. But if we feel like there's a real issue, we'll get you in, even for some situations like this, on a one-on-one basis. If you're not getting milk production by day 4 or 5, now again, for first-time moms, you've probably already seen us at that point in time, and we probably kind of talked you through our concerns and set up a plan for you. But again, if we feel like there's ongoing concerns, we want you to call us and get back with us anytime. So I'll tell moms, by next week, if you're not pumping X amount of milk, I want you to call me. Let's come back and do a pre and post weight feeding. So we are available for you to call and consult with us. One of the things we want to talk about, especially in relation to engorgement and not having good milk production, is mastitis. And that is a hard, red, tender area on the breast. You have flu-like symptoms and you spike a fever, okay? A hard area on the breast, obviously the engorgement is kind of hard. Sometimes it can even be really red. I'm not too worried about it, but when you start feeling really bad and when you start spiking that fever over, say 101, then you've probably got an infection in the breast called mastitis. It doesn't mean anything's wrong with the milk, it just means that the milk's gotten out to the tissues of the body and it's caused an infection in the tissues of your body, and you need to get on some antibiotics. That would be something to call your OB doctor for, so that they can get you on some antibiotics. But hopefully, if you just start noticing the signs of a real hard area, the engorgement, maybe even a little redness, or a real lumpy area, what we call a clogged duct, you can work on that with the massage, with some pumping, with some warm and cold compresses, and you can actually relieve that before it gets to the point of being a mastitis, okay? And so that's what we like to really talk to you about trying to be vigilant about watching those kind of things so that you don't get to the point of having an infection. And again, if you're not sure, call us and we'll talk you through. We'll remind you some of the things to do. We'll remind you again, of course, when you discharge. But many times we can keep this from happening if you're just vigilant about watching your breast and what's happening with them and keeping the milk drained well. And again, we've talked about ongoing nipple or breast discomfort. We are available to help, either whether it's by phone, consult, or in person. And about milk production, even sometimes, down the road, sometimes moms go back to work and then they've been doing great at home, and going back to work is very stressful on moms, and trying to get used to pumping, and a lot of times they'll see a real hit on their milk supply. And so if you're having some questions about that, whether it's 2 months, 3 months, 6 months, or whatever out, call us and we'll talk you through that, and we'll try to help get a plan for you to make that better. There's herbal supplements out there, there's power pumping. Sometimes it's just a difference of pump, sometimes it's pumping schedule, those kind of things that make a big difference in how that milk production is going. And then we talk about the goals for breastfeeding. A lot of moms, their goal is to breastfeed for the first year of life. And as this mom's saying, every time the baby turned a month older, they felt really good about their accomplishments. So let's look at some of the recommendations. The American Academy of Pediatrics recommends exclusive breast milk for the first 6 months of life for your newborn. And that means either you nursing at the breast, direct breastfeeding, or pumping your milk and putting it in a bottle. Okay? If you have to use anything else in those first 6 months, it should be a newborn formula, not any solid food until they're 6 months old. And then from 6 to 12 months, you'll still have your breast milk, because babies don't need to take whole milk until they're a year old, so you wouldn't want to change to whole milk until then. If you had to change from breastfeeding for whatever reason, it would be maybe even your pumped milk that you'd saved. A lot of moms have so much milk in the freezer that they can quit breastfeeding and just give their pumped milk for the next 6 months or whatever. Or the other possibility would be going to one of the formulas. But you would start solids at that point in time, and your pediatricians will recommend how to do that and when to do that. But typically at 6 months you start usually with, now they're saying, the fruits and vegetables, and then going to your meats and cereals. Always introducing one thing at a time, giving that for a couple of days, making sure they don't have any allergies before you introduce the next thing, and not giving products that have multiple things in them until they get a little bit older and you've been doing foods for a little while. And then 12 months, if you want to breastfeed past that, that's certainly fine. The World Health Organization actually suggests anywhere between 2 and 7 is when moms should wean. Now you have to remember that the World Health Organization is looking worldwide and not just in one area of the world. But many moms here do breastfeed till 12, 15, and even 2 years old, and that's fine. Most kids are eating other foods by that time, and they're really only probably nursing maybe 3 or 4 times a day, morning, night time, bedtime, that sort of thing. But that's really a decision between mom and baby, and many babies go through times that are around 9, 12, 15 months. It's pretty easy to wean if that's something that mom and baby decide that they're ready to do, and then others decide that they want to do it a little bit longer. And a lot of times they'll just wean gradually. They may take away the nap feeding, they may take away the morning, whatever works for their agenda. Usually the nighttime feeding is the last one to go, because that seems to really help in that whole bedtime routine. And it's very important that you take care of yourself, that you rest when you can, limit your activities and visitors. And at this point we're talking about home, because we're already limited very much here. Home is a little bit nicer in that if you do have visitors, you can kind of leave them in the living room, and you can go to your room if you've got to feed or pump, or just need to get away from everybody if you've got family from out of town or whatever. But don't be afraid to take that time for yourself. People are offering to do things for you. Let them bring you food, let them do your laundry. You need to take care of the baby and take care of you. You need them to do the other things. You want to make sure that you're drinking lots of water. That's really important in making a good milk supply, and you want to make sure that you're eating healthy foods. A lot of moms ask us, do I need to not eat anything? Mainly you just want to concentrate on eating healthy. Spicy things probably sometimes can cause some babies problems. Dairy products sometimes can cause some babies problems, but I don't say cut those things out unless you start to see a problem with something, and then we would kind of look at your diets. But overall, you just want to eat healthy. Probably the only thing to really stay away from would probably be raw fish, and just again concentrate on eating healthy. Make sure you're kind of snacking with good snacks throughout the day, because you're going to be burning a lot of calories. And of course there are things out there like lactation smoothies and lactation cookies that have things like brewer's yeast and flaxseed and rolled oats that are good for helping you make milk. And there are herbal supplements that you can take if you're having a true supply issue. We can talk to you about that if you need to boost that supply. And finding a support system. Right now, I guess with family, or we do have a Facebook support group that we encourage you to join, and that link will be on the website as well. I hope to see, as I mentioned earlier, maybe a Zoom support group in the future that we can do more interacting together virtually, so that moms that have been breastfeeding for a while or have breastfed multiple babies can support some of these new moms, because it is hard kind of to adjust and adjusting to going back to work and that sort of thing. So find those support systems that you have either within your family or maybe your church family, friends who have breastfed, because they can be a good sounding board for you when maybe things are not going so well, or you're at home by yourself and baby's been really fussy and you need that other adult to kind of talk to and vent to a little bit. And that's okay. And partners, dad, grandma, whoever your support person is, can be very important in helping you get through, especially those first couple of weeks. Those hormones are raging, especially as the milk comes in, and just trying to get used to everything and get up and not getting your sleep like you're used to, particularly if you're not a night owl. Most babies are night owls because they're used to, when you lay down at night, they were probably their most active, and they kind of keep that pattern of sleep for the first couple of weeks. It gets better as they get closer to that month old, 6 weeks old. But in those first few weeks, you need to rest when they rest, when they sleep during the day, so that you're not so worn out when you're up in the night feeding. So partners can be very important in helping that and taking a turn, letting mom just sleep, trying to console the baby, maybe even doing some pumping and giving the mom's pumped milk on one of the feedings during the night, turning the lights down, keeping the room quiet, bringing mom a glass of water, helping her prop the pillows when she's feeding, just staying positive and just being there for her, just giving her a hug and telling her she's doing a good job. Let's talk a little bit about substances of concern. It's always funny to me that we always get a lot of questions about alcohol and stuff around New Year's and 4th of July. We even had one time where it was the 21st birthday. So, if you are going to go out and drink a lot, you need to pump and dump, okay? If you're going to have one glass of wine, one beer, that's probably not a problem. If you're going to feel the effects of it, so if that's 2 beers for you, then you need to pump and dump once. If you drank a lot, you might need to pump and dump once or twice. But you don't need to be on a regular basis doing that and breastfeeding your baby. You don't need to smoke and breastfeed your baby. It will actually decrease your supply. And hopefully you weren't smoking during your pregnancy, so hopefully that's not an issue. And you don't need people around your baby who smoke. You don't need that secondhand smoke because that can cause respiratory problems for all of us, but particularly for your baby. And you certainly don't need to use any kind of illegal drugs or abuse prescription drugs in breastfeed. Now let's go back to the top one. Not all medications are safe, but the vast majority of them are. Medications are actually classified through L1s to L5s by a system with Dr. Hale and his staff out at the University of Texas. And L1s and 2s are fine to take while breastfeeding, and L3s are borderline for different reasons, and L4s or 5s are our contraindicated drugs. So if a drug is an L4 or 5, then we would not recommend taking it in breastfeeding. If you had to take it for some reason, you would have to pump and dump, depending on the drug, how many times or how long, how many hours afterwards, because medications stay in your system at different amounts depending on the particular drug. Okay, so we can look up that information for you. We have a reference called Medications in Mother's Milk, and that would be true also for things that you might have, radioactive mediums that you might have, like with a CAT scan or something. We can look those up as well and see if you have to pump and dump for 24 hours or just one time or 3 days or whatever. Again, it depends on what the particular substance was, and so we can look that up for you if you have any questions, because many times the other places don't have that resource like we do here to look that up for you. So let us know if you're getting ready to have some kind of procedure. We'll try to check into that. If you get a prescription and somebody tells you need to pump and dump or you can't breastfeed at all, please call us. Maybe pump your milk until you can get a hold of us, and then we'll look it up and make sure that's the case, because I've had moms that were just getting amoxicillin, which is an antibiotic that we give to babies, and somebody told them they had to pump and dump, and I don't want that to be you and you pump and dump for no good reason. So call us and let us know. Some medicines are what we call L3s, that's, as I mentioned, borderline, and that could be something like Sudafed or steroids, and it's because they decrease supply. So you don't want to decrease your supply, but it's not necessarily really because it causes a problem for baby. Some things like Percocet, which we give moms after a C-section, is an L3 because it's a narcotic and you wouldn't want to take that long term, but if you just had surgery, a C-section, you got to take something. So that short-term use is okay, long-term use would not be. So those are the kind of things that we look at for you. So if you have any questions about any kind of medication, please ask us, whether it's when you're in the hospital or if you go home and something's prescribed to you, or like I said, you have a procedure, let us know and we'll check into that for you and get you an answer. In caffeine, if you're a Coca-holic or a coffee-holic in the morning, you know, one cup of coffee in the morning, one Coke here or there is not probably going to hurt you or baby. But if you're drinking a whole lot of it, well, I mean, that's really not good for you on a regular basis, but definitely not good for you and baby. And so returning to work, as I mentioned earlier, can be very stressful for moms. You know, getting back on that routine of going back to work, being away from your baby, who's keeping your baby. Those are things that you need to be thinking about now, because it's going to be hard enough to get into that different routine without having things kind of set up. You need to make sure that you're getting a pump, so you'll have a pump to be able to pump. You need to know your rights as far as pumping at work. You do have a federal and state law that says that workplaces have to give moms a place and the time to pump. So be working that out with your employer, hopefully ahead of time. Be ordering your pump ahead of time so you have that and get used to it. Many times moms need the pumps in the first few days home anyway, and many insurance companies do provide pumps, so that's great to know too. Try to take off as much as you can. If you can take off 12 weeks, that's wonderful. When you do go back, if you can go back maybe a half a week at first or half a day so that you can kind of ease into it, that sometimes seems to help it a little bit more. Certainly if you can work part-time, that's a great way. And I know a lot of people now are able to work virtually, and so, you know, in those first couple of months, you probably can pretty much do that from home. You can still keep your baby, and that'll be nice too. Of course, as they get older, they do require more care, so you will have to come up with a different plan there. But, you know, again, easing into that whole routine makes it a lot easier on mom and on baby. And do start that pumping routine and trying to get a supply established in the freezer so that you've got a stash. You're not just counting on what you pump one day for the next day. You've got some reserve. And start giving your baby a bottle at least the end of that first month. If you know that you're going back to work, whether it's 6 weeks or 12 weeks, if you wait till the 12 week to give the baby a bottle, you may have a little bit of trouble getting the baby to transition from just breastfeeding to the bottle. So you know you're going to have to give your baby bottles at some point. I would suggest starting that within the first month or so. So we talked about hand expression, and that's certainly a way to store some milk or to help. If you're out and about and you're getting really full, you could literally, particularly as breastfeeding is more established, you could squirt some milk right into a bottle if you needed to, for comfort or because you need to give your baby a bottle. But when we talk about expressing your milk as far as like work and that sort of thing, we're talking more about pumps. And let's just look at a couple of things here. We did mention the hospital grade pumps earlier in the class when we were talking about situations where we would set you up to pump. And that's what you see in this bottom corner here. Ours look a little bit different. We have Medela Symphony pumps here. This is the Hygia electric pump. Actually, Medela's pump used to look kind of like that, except it was blue. We have still some of those older ones too that we might use from time to time. And a hospital grade pump is just a little bit stronger, and it's a multi-use pump. So you get a kit that fits into that pump, but multiple people use it. Has a little bit more power to it, but it's a closed system, so nothing's going through that. Okay, so that's why it's a hospital grade pump. Obviously they're a little bit more expensive, but multiple people can use it. So we give you a kit that's yours, your pieces, but you plug into this unit that belongs to the hospital in this case. You can actually rent hospital grade pumps if you find that you are pumping better with the hospital grade pump, or let's say you have a baby that's in level 2 nursery, you can rent a hospital grade pump. We actually have a local pharmacy that does rent those. And some insurances will actually cover that if you have a baby in the level 2 nursery, even while covering your single user pump. Okay, so let's talk about single user pumps. That's the one in the top corner here. That just happens to be a Medela product there. There's a lot of different brands out there, and you can do some research. We're glad to answer some questions about that. If you're on our mom's Facebook page, there's probably a lot of comments out there, recommendations for, against, whatever. But that's a pumping style backpack, and it comes with all the pieces that you need, along with even a little ice chest thing in there with the little things that go in between the, you put it in the freezer and you make them cold, or you make them frozen to keep your milk nice and cold. So that's a real nice set to have, and again, lots of different companies have that same setup. But that pump is for one person. So it's, when I say single user, it just means a single person. It's a double pump, see the two sides, so it's going to pump both sides together, and that's what we want to do most of the times that we pump, because that's more efficient, obviously, because you're getting done both sides at one time, and it's actually more productive, because many times when you're, for instance, feeding on one side, you're leaking on the other. So if you're pumping on one side, the other side's probably leaking. So if you're just pumping both sides together, then you're doing a much better job, both efficiency and productivity. And so that would be what you would get. Again, many insurances and most insurances cover a pump now for moms, and that does require a prescription. And that's something that you should be asking your OB doctors for at somewhere around 34 weeks, I would say. Go ahead and be setting up getting that. Again, we have a local pharmacy that has those in stock that you can get them here. Some insurance companies do require you to go through an online thing, but most of them you can get wherever company you want to, whether it's local or another mail order thing that you want to get them through. So do check into that if your insurance covers it. If you're going to need that prescription, and go ahead and be getting that ahead of time. Sometimes people will say, well, I want to see how it's going to work. Well, it's really important to have that pump when you deliver, and I'm not necessarily saying that you have to bring it up here with you, but if you have any problems, if you have a sick baby, if you have a milk supply issue, one of the first things we're going to do is get you pumping to help, if you're going to be separated from baby, obviously, or to help production. And if you've got to wait to order that pump, it's going to take 2 weeks to come in, we're kind of already behind on what we need to do. So get your pumps ahead of time, have them, that way if you need them. If you want to bring them when you come up here, you can. We're glad to go over them with you. You don't have to bring them because we're going to set you up with a hospital grade pump if you're in need of a pump. As far as for a problem, we don't recommend pumping if there's not an issue going on. Just breastfeeding your baby in those first few days. But sometimes there is reason to pump, especially when you get home, so I want you to have that pump when you get home. So if you have any questions about that, about getting a pump or getting a prescription or whatever, please let me know. And then finally is our manual pump, and there's lots of different ones out there. Medela has a manual pump. This happens to be an 8-minute pump. There's a new thing out there called the Haka. A lot of you have probably heard about it. It's basically just a bulb syringe, and you just push the suction on it, stick it on your breast, and it just, by the suction, just pulls the milk out. And moms are loving that. When they're feeding on one side, it's pulling the milk out on the other side. It's not really a hand pump in that you're not having to pump it, it's just pulling it by suction. So, but it is a nice thing to have. They only cost like $12 or $15. You get them on Amazon or at Target. But hand pumps like this have a little lever back here or some sort of piston that works by. And those are nice to have just if you're out and about. And again, like I talked about Hand Expre, you just need to pump a little bit because you need to give the bottle to the baby because you're going in somewhere that you're not going to feel comfortable breastfeeding or whatever it might be. Or you're just feeling a little uncomfortable. Maybe you're away from your baby and you didn't bring your big pump. So it's just something to maybe kind of have as a backup. So those are the different kinds of pumps. Again, if you have any questions about that or about where to get your pumps or about getting prescriptions, please let us know. All right, a lot of questions we get about storing milk, and this is just one of many little reference tools out there. Typically the pumps have that in their booklets that come with the pump, the booklet that we give you, a handbook that we give for new moms. Postpartum League has a little reference in there about how much. CDC website has some great little charts about how long milk can be stored and that sort of thing. But just as sort of a rough reference, I like to remind moms to kind of think of it in this way. 5 hours freshly pumped. You just pump the milk and you're going to give it within the next 4 or 5 hours. It can just sit right here on the table. That's freshly pumped. 5 days in the refrigerator, 5 months in the freezer. Now again, that's just a kind of a rough estimate, and that's a 5-5-5 thing. It's easy for me to remember, easy for you to remember. But if you want to really get down to the nitty gritty, it's really about 3 to 8 days in the refrigerator, 3 to 6 months in a refrigerator freezer, and 6 to 12 months in a deep freeze because you're not opening it as much. Okay. An insulated cooler, like we're talking about, that comes with some of the pumps. It's good for 24 hours. And again, this one doesn't have it, but just pumped, you don't, and you know you're going to use it the next couple hours. You don't even have to put it in the refrigerator, so you won't have to warm it or anything unless the room happens to be really cold. And if you are putting milk in the refrigerator or the freezer and you've got to warm it up, Bottle warmers are fine, or just a cup of hot water. You never want to put any breast milk in the microwave because it will actually kill the living cells in it. And you really don't want to put any baby milk food in the microwave because it heats unevenly. So we would recommend heating it. So you can put the water in the microwave and warm it up, but not the milk itself, okay? And the big thing to remember about frozen milk is that once you freeze it, you've got to use it within 24 hours because the properties in the milk that keep it fresh for so long are killed by freezing. Okay, so once you thaw it out after it's been frozen, you've got to use it within 24 hours. Now that doesn't mean you sit out on the counter and let it thaw that whole time. You put it in the refrigerator and let it gradually thaw, or if you're using a bag that you're going to use right now, so you've got a 4-ounce bag of milk, you just go ahead and thaw it out again in your bottle warmer or in some hot water in a cup. You can just change the water out several times and you can warm it up right then. You could go ahead and thaw it out and then put it in the refrigerator to use a few hours later, or you can unthaw it as you use it. But once you thaw it out, it has to be used within 24 hours and you cannot refreeze it. Okay? And as we mentioned before, we are more than happy to take calls, text messages, emails. So I think we have a good system of support. We have 4 of us on staff here. When you come in, again, you'll get some handouts that have all of our names and numbers. So please feel free to get in touch with us. So that's a resource you have here. I hope to see us having more resources as things have changed a little bit. We had a support group that met. We're not going to be able to do that going forward, but hopefully we'll have some Zoom meetings, that sort of thing. Finding your own group of friends that know you have breastfed. Getting on our Facebook page. That link is on the website. That's a great, we have like probably 3,000 or 4,000 moms on there now. Some have, long since been done with breastfeeding, but they have they're a great resource. And you can ask questions. Ask them about products that you might be thinking about buying and see what their opinions are, that sort of thing. You've got the option of seeing us, whether it's in that first week or down the road. Again, there's no charge for our outpatient services. You just do need an appointment. If you have had a doula, many times they offer postpartum and breastfeeding help post-delivery. We talked about the support groups, and that would be all a virtual situation right now. And for those who maybe are in the WIC program, they do have some nutritionists that are very supportive of breastfeeding and can answer some of your questions, and if not, they can put you in touch with us or someone who can. So there, are some hurdles, as I mentioned, getting over the first couple of days. It's kind of a new ball game. Babies are trying to figure out why you evicted them from their nice warm apartment and what happened to their 24-hour room service and how it is I'm supposed to eat. And I've really got to work for my food now. But if you work with them, if you use the resources that we have here for you, we'll help you get off to a good start, breastfeeding your baby, having a good milk supply, and having the resources that you need to keep you going well through those first couple of months and hopefully through the first 6 to 12 months of your baby's life so that you can give your baby the best thing for them, your breast milk, with the antibodies, the nutrients that only your body can make for them. Have a wonderful day, and we look forward to seeing you all very soon. Thank you so much.